Yes, Juliet Nabyonga from WHO. I'll try to go very fast. Perhaps we're tired and we have to move on. So I'll be talking about lessons from mainly the WHO African region and beyond in optimizing decentralized health services delivery for UHC. I want to straight on go to this, to trace the history of district health systems dating as far back as the Alma Ata Declaration in 1978. All the commitments we've been talking about, the strengthening district health systems based on PHC, the International Conference on Community Health Systems in the African region, Bamako Initiative, all these have reiterated the central role of district health systems in service delivery up to today when we talk about SDG, SDG3 and UHC. So the commitment dates as far back, and we've been reaffirming that every other year in every other international platform to date. But what do we see is that our district health systems still remain weak, remain under-resourced, remain under-managed. And we learned a lot from the Ebola outbreak in West Africa, where actually districts failed to really rise up to the challenge, to respond to the outbreak, and also failed to keep basic essential services going. There was a breakdown in the system, and that really emphasized the point that they were weak even before. But we also noted that during that time, vertical programs were doing well. Before that, vertical programs were doing well. The vertical approaches were going, but not the broad system, not the broad management. So when there was an outbreak, we lost all the gains, but also we lost lives. Now, I want to talk briefly about the situation analysis, and this is what we've seen regarding district health systems in the last so many years. And the data I'm going to present dates as recent as 2017, when we did assessment of district health systems in Africa. And I'm going to talk about the situation of district health systems up to 2017. This is what we've seen in the African region. One, they grew out of hospital services, and they've remained curative-based, paying limited attention to preventive services. The vertical approach remains, and we are yet to see horizontally networked district health systems that can really provide services that are people-centered, that can address local priorities. We are still more into the vertical approach of doing things, building onto the MDG momentum that focused on communicable diseases, maternal and child health conditions. But what we want to see regarding district health systems is horizontally networked services with referral mechanisms within the district and a network of health facilities supporting service delivery. Now, perhaps that explains, and I think definitely that explains the poor health service delivery we see today, where unavailability of drugs and equipment is still prevalent, attitude of health workers is known to all of us, delays in provision of care, and we can go on and on. Quality concerns, access concerns, these really do persist. But also, I remember one of the why we went into decentralization, we wanted to get communities to participate in service delivery. But what do we see? We are not yet there. When you look at the involvement of communities in decision making across the board, less than 50%. And we have varying percentages. This is East and Southern Africa, West Africa, and Central Africa. We are below 50% in all the sub-regions. But on the other hand, communities are really willing to participate in service delivery, to contribute to service delivery, to participate in policy processes, the high willingness again across Africa. Now, the tensions between comprehensive and selective PHC persist. If you may recall, when we talked of PHC, we talked about comprehensive services that are people-centered, meeting local needs, but actually the implementation took the other way. Largely driven by limited resources. So we went into basic package, prioritized within the priorities, so we've been focusing on limited packages as opposed to comprehensive packages. And of course, the donor preferences only served to really push us more into that direction, because we've been through an era of global health initiatives that are focusing on certain diseases, certain programs, and this is what we've seen, and we refer to that as a selective PHC, which actually persists even today, because even as we talk of UHC today, we are still talking about the Global Fund. We are still talking about Gavi. We are still talking about rollback malaria. So those are some of the things we need to watch out for as we really embrace the UHC commitment. Now, I've talked about the recognition of the need for a responsive and resilient district health systems. If you may recall, previously we're not paying so much attention to responding to emergencies and outbreaks within district health systems. But now what we learned from West Africa is that actually that's where we need to start if we are going to control outbreaks in a timely manner. Now, achieving UHC requires that district health systems are integrated, are people-centered, community-oriented, are well-managed and accountable. And I'll come back to some of these points when I talk about the strategic shifts, the new thinking in district health systems that we need to embrace in order to get the district health system that can anchor UHC. Now, these are the challenges, again, from the summary of our synthesis and review of district health systems within the African region, and I'll talk briefly about each one of them. One thing we have seen is insufficient decentralization. Now, we are all well aware of the different modalities of decentralization, deconcentration, devolution, delegation. I want to talk more about deconcentration and devolution, because delegation, I mean, that's not the model we want. You're just getting people from the central office to go and sit in districts and do exactly what they would have done if they were based at a central level Ministry of Health. Now, what we see is that even when you talk of deconcentration, and here I cite the example of Zambia, moderate power transfers, people are not empowered to do what they should be doing. But on the other hand, we have radical devolution in Kenya, really pitched at the level of the president. But what did we see? We got empowered local government, but not empowered local district health teams. So this insufficient decentralization results in a narrow decision space. They cannot take decisions regarding resources, they cannot hire and fire, they cannot be innovative because they are still restricted, much as theoretically power has been given to them. And I put something what we call as destructive PHC. Because when you decentralize, you need to train people. They must have the capacity, they must have the tools, they must have the guidelines, they must have the resources, then they can provide PHC. But if you do not do that, then we cannot get there. And that's why I refer to this as destructive PHC, because people are in charge of service delivery, but actually they cannot. And perhaps that explains our previous criticism of poor performance in the league table Christine has talked about, because they are supposed to do it, but they don't have the money, they don't have the tools. Now, the other point I want to raise regarding limitations is the financing and resource allocation. Sorry, it's running off from the screen, but what we have here is that huge reliance on central level grants. And much of this is in salaries. Such that they don't have money to put into operations, money to put into things like supportive supervision. So they have the wage bill, health workers are paid, but they cannot do much. The districts, although they are autonomous entities in the devolution kind of, if we are talking about the devolution model of decentralization, they are autonomous institutions, but they do not have the capacity to generate local funds. And perhaps we need to relate it to this very closely in the multiplicity of districts in Uganda, where some of them are small as a village. There is no way they can raise resources to provide any services. And we expect so much from them. Now, the other point is the limited effectiveness due to national control. And I love talking about this because there is decentralization is granted, be it devolution or deconcentration, but actually people are not skilled to do that. And what I've seen in countries, I think it's a tendency to hold on to power. They're not keen to train them. You ask them, why don't you train them? Oh, no, they cannot rise up to the challenge. And in some of the countries, for example, Lesotho, you're talking of graduates. I wonder what kind of training that is that a graduate cannot grasp the management concepts to really implement what they are supposed to do. So we are caught up in that trap. It's true, they don't have the money, so they hold on to managerial processes, to budgeting, to planning, but also they are not training them to. So actually the decentralization of Lesotho is maybe even older than Uganda, Christine. I think dating as far back as the mid-90s, but up to today, you cannot even tell where they are, yet they set out to go for devolution. They are more into delegation. Now, looking at community participation and engagement, this question, again, I tried to say something about this in the morning. When you look at the district health systems today, the community voice is little heard. They've been instrumental in helping building health facilities. They've been instrumental in coming up to take up our services, but they're not participating in policy processes. They're not participating in holding health workers accountable. They are not participating in the key issues that relate to their health. Partly because we do not have structures in place, but also we don't have resources and time, because really getting communities to participate requires time, and we haven't invested enough in that regard. Although policies are in place, guidelines are in place, but these are little implemented. And again, we see this in Lesotho, Tanzania, Botswana, but also in many other countries. I just highlighted a few here, but you can say the same even about Uganda. Communities, their voices are little heard. And also maybe the question is, who should bring community voices? Definitely civil societies are not doing that. VHTs are not doing that. Community health workers are not doing that. But also the other question, politicians are not doing that. But also the question is, who is a community? You know, it's not as simple as, maybe even us here we are community. But how do we engage in these processes as community, and how do we engage maybe as technocrats? But also there are those whose voice can only be heard from that level. Now, on this one, I want to give a quote from one of the senior health policy researchers within Africa, Kwame, who, this is one of the conclusions in her paper regarding decentralization in Ghana, stating that the rhetoric of decentralization does not always mirror actual implementation, nor always result in empowered local actors. This is a study from Ghana, but I think we can say this for many, many countries within Africa. Now, I want to move to what opportunities do we have. We've made commitments over the years, but perhaps we have opportunities now that give us leverage to really strengthen district health systems. I think SDGs, universal health coverage, is one of the opportunities, given the broad scope, where we need many actors, where we need strong districts to anchor UHC and PHC, where we call for a holistic approach, because one of the tenets in there is leave no one behind. So we can no longer go selective PHC, we have to go comprehensive PHC. So that in itself provides an opportunity to have districts that can generate data, identify local needs, and put together a package of service that they can provide to their communities. And I think I want to also talk about the point of lessons learned from earlier experiences, strengthening district health systems initiative, but the Ebola outbreak in West Africa is also another important landmark for us, where now we are saying that health security should primarily be built at the district level.
3 minutes.
Yes, this is my last, I think. Now, we are talking of districts that can anchor PHC, and I want to talk about the strategic shifts that we need to embrace to take us there. One is about engendering adaptive leadership. We must build capacity in leadership, but also we want a unique type of leadership that is innovative, that is creative, that can generate lessons and learn from them and continue to improve, as opposed to implementing guidelines from the center. I'm not saying that their creativity and innovation should contradict national level aspirations, no, but to really solve local problems within the rules and the guidelines of the Central Ministry of Health and local government for that matter. Reducing verticality, encouraging the greater policy ownership and resource control. They must have that ability to really own their problem, create their solutions, and create their solutions and implement them. So they must have control over their resources, and resources here we're talking about money, we're talking about human resource. Now, Vento talked about decentralizing health workers, and I'm sure we'll come back to that debate, but really they must have control over the resources for them to do exactly what they want to do. If we have built capacity and they are creative in addressing problems. We're talking about promoting integrated and comprehensive district planning, reconceiving accountability. Christine again talked about this briefly. We talk about bureaucratic accountability, which is more of comply with standards, with guidelines, with the Auditor General requirements, but we want also to bring in that accountability where the communities can hold health workers accountable. Where even health workers know we have something to give to the community and we fulfill our commitments. So these two are opposed to each other, but we need to find a balance. Changing organization incentives to support increasingly less dependent district health systems. This is an issue of resources. Can they generate local revenue? But what options do we have? Because reliance on central government grants has its challenges. It doesn't give much room for decision making, doesn't give much room for innovation and creativity. That was my last.